Hi and welcome to the channel. In this video, we're going to talk about endometrial hyperplasia. What is endometrial hyperplasia? It is the excessive growth of the inner lining of the womb, which we call the endometrium. It is caused by the unopposed effects of the hormone estrogen on the endometrium over a prolonged period of time. During a menstrual cycle, estrogen causes the endometrium to thicken, while the hormone progesterone prepares the womb to receive a fertilized egg. Endometrial hyperplasia typically presents in menopause, but can also be present in women nearing menopause. As endometrial hyperplasia is caused by an excessive amount of estrogen, people at risk of the condition are those who are overweight or obese, people with polycystic ovarian syndrome who have infrequent cycles, the use of estrogen hormone without progesterone cover, those on tamoxifen, women who have an estrogen-secreting tumor in the ovary, women who never had children, and those with diabetes are also at risk of endometrial hyperplasia. Interestingly, the use of the combined contraceptive pill reduces the risk of this condition. As prevention is always better than treatment, we advise people who are overweight or obese to get support with weight loss. And women who are diagnosed with PCOS and have infrequent periods and are not planning to have kids soon are advised to use hormonal contraception. The commonest symptom of endometrial hyperplasia is abnormal vaginal bleeding. This could be a postmenopausal bleed, or a bleed in between periods, or a period that suddenly becomes heavy or prolonged. When people have such symptoms, they may be offered an ultrasound scan. This is often performed transvaginally, which means that part of the ultrasound probe is inserted into the vagina. This gives us better image quality compared to an ultrasound scan performed through the tummy. A scan will tell us the endometrial thickness, as well as potential causes of the abnormal bleeding. Women who have gone through the menopause should have a thin endometrial lining, and so a thickened lining needs further investigation. The best way to diagnose endometrial hyperplasia is by taking a tissue sample and having a look under the microscope. We can take a sample in two ways. Firstly, a papal biopsy. This is done via a speculum assessment, and a thin flexible rod is inserted through the neck of the womb to obtain a sample. The other way of collecting a sample is with a hysteroscopy. A hysteroscopy is a thin rod-like camera that allows us to look inside the cavity of the womb. This also allows us to identify other causes of bleeding, such as polyps, which are small and often benign growths, like a skin tag. Hysteroscopy is often done in the outpatient department whilst awake. Occasionally, it may be performed as a day case whilst asleep. Endometrial hyperplasia can be divided into two types: endometrial hyperplasia without atypia and atypical endometrial hyperplasia. Without atypia means there is an excessive number of cells crowding together, causing the lining to become thickened, but all the cells look normal, while atypical hyperplasia means that the cells do not look normal. Although both without and with atypia can increase the risk of endometrial cancer, their risk profiles are different. People diagnosed with endometrial hyperplasia without atypia have a 5% chance of developing endometrial cancer in the next 20 years, whilst women with atypical endometrial hyperplasia will have a higher chance of developing endometrial cancer. Without treatment, 8% will develop cancer in 4 years. 12% after 9 years, and 28% within 20 years of diagnosis. In fact, a study showed that when atypical hyperplasia is diagnosed, up to 43% have cancer confined within the womb. In cases of endometrial hyperplasia without atypia, the first-line treatment is with the hormone progesterone. This is typically administered as an intrauterine system, such as a Mirena, but can also be given in tablet form. Intrauterine systems are also very effective forms of birth control. Progesterone treatment causes the lining of the womb to thin down and is given for a minimum of 6 months. The intrauterine system is more effective than the oral tablets, and so it's our first option. We would take another sample 6 months after treatment. If 2 samples taken 6 months apart show no hyperplasia, we would say there's full regression of the disease. Sometimes we may advise continuing with treatment or monitoring if there is a high risk of the disease returning. The other option is to not treat the disease, but instead monitor the condition with regular samples. Although the condition may disappear on its own, it is not as likely as it is with treatment. If after 12 months of treatment there is still hyperplasia, we would recommend a hysterectomy. For women with atypical hyperplasia, we would recommend a hysterectomy due to the risk of progressing to cancer. We would also remove the fallopian tubes, as this reduces the risk of ovarian cancer in the future. Your surgeon will also discuss with you the benefits and risks of removing the ovaries. This is often done via keyhole and vaginally, and can also be achieved robotically, but may sometimes require an open procedure. If a woman with atypical endometrial hyperplasia has yet to complete her family, a careful discussion with a gynecologist specializing in cancer is required. They may also refer for a consult with a fertility specialist. Give this video a like if you found this helpful, share, subscribe, and I'll see you again soon.